So let's start with the SNI, Meglumi, ferritin, analyte. So in this essay, in Meglumi ferritin assay, we have a three parts. One part is the physiological basis. Second part is the clinical application. The third part is a SNI ferritin. So in this three parts, we will discuss about the ferritin. So if we talk about the physiological basis, let's talk about the ferritin. So you can see here the ferritin is basically a spherical protein which contain a 24 non-covalently linked subunit, which has a molecular weight of approximately 50,000 daltons molecular weight. And this subunit form a shell surrounding a central core variable amount of ferric hydrophosphate. So the one molecule of the ferritin is capable of binding with the 4,000 and the 5,000 atoms of iron. So this making the major iron storage protein for the body. So this ferritin has a threefold pores and the H subunit dimers and the subunits pores, which helps to store 4,000 to 5,000 atoms of iron. So this is the biggest storage protein for the body, and that helps to store the iron for to maintaining the blood oxygen from different organs, from the lungs to the different organs. So if you talk about the location, you can see here due to the circulating erythropoietin levels, due to the RBC cycles and the macrophages and the utilization of the bone marrow, the plasma transferrin levels cause loss and the absorption process to the dietary habits, maintain the plasma transferrin levels, and this storage of iron liver variables from that, and the heart and the pancreas and the myoglobin utilization as these locations. So if we talk about this, we can go to the further about the more functions. The ferritin is basically found chiefly in the cytoplasm of the cells of the reticuloendothelial systems, and is basically constitute of the normal human serum. And in the healthy people, about 70% of the iron is absorbed by the body, is incorporated into the hemoglobin of the RBCs. So if most of the remaining 30% is stored as an ferritin, it's in a hemosiderin or a complex iron protein and other materials. So also the ferritin and hemosiderins are also present primarily in the liver, but also in the bone marrow, spleen, and skeletal muscles. So these are the sources of ferritin, and then they can store at different organs, different tissues. So if we talk about the metabolisms, according to the clinician, there is a ferritin structure of apoferritin forms and a roughly spherical contains, which is formed in ferric hydrogen in the stored as a ferric hydroxide minerals. So you can see here the metabolisms of that different type, that the labile iron pool has an utilization of hemosynthesis and electron transport for the ferrets, S biogenesis, and the free radical damage of the DNA export cause the intracellular iron homeostasis. So this ferritin storage of the iron function as a ferroxidase, converting Fe2 plus to the Fe3 plus as an iron in the internalized and the sequence into the ferritin mineral core. And this reactive species shows as a yellow sphere can directly damage DNA and the protein. So this divalent metals ion transport TF transferrin and the transferrin receptors, and this is all about the metabolisms. So if this structures is moves and then this metabolism occurs. So if we talk about the physiology of the ferritin, you can see in the normal body, there is a normal amount of RBCs are present, including the red blood cells, platelets, and WBCs. But in the anemic conditions, the numbers of RBCs is comparatively low, and if they have an RBC, the shape is changed due to the iron deficiency anemia, and that may leads to the anemic condition. So the patient with the iron deficiency anemia have a serum ferritin concentration approximately 1/10 of the normal subject. So this patient with the iron overloaded, like hemochromatosis, hemosiderosis, have a serum ferritin concentration much higher than normal. So you can differentiate iron deficiency anemia with hemochromatosis or hemosiderosis with the ferritin levels. So this serum ferritin level concentration may serve as a tool to monitor the effect of iron therapy, and but results should be interpreted with the caution, as they cause cases may not always reflect the true state of iron state. So you can see that you can rule out the serum ferritin concentration, high and low value, to differentiate the iron deficiency anemia and the hematochromatosis or hematosidosis in the patient. Or you can use this tool to monitor the effect of iron therapy, but it's not as much as reliable than the other tools. So if we go to the further physiological basis, the ferritin positive accused phase reactant in both adult and children, whereby inflammatory results is disappropriate increase in the ferritin related to the iron results. So you can see here that's in a different stage where due to some inflammatory stage or some elevated ferritin levels maybe increase observed in the acute chronic liver disease, chronic renal function, and in some cases of neoplastic disease also cause the increased level of ferritin in such patient as well. So if we talk about more the physiological basis of this, you can see that the iron deficiency overload, there's a sharp rise in the serum ferritin concentration in the first month of the life of the babies. Within the 2 to 3 month, erythropoiesis become reactivated, and there's a drop in the concentration of serum ferritin. By the 6th month, the concentration is reduced by a very low level where they remain throughout childhood, and there is no sex difference until the onset of the puberty, when the time ferritin concentration rise, particularly in the male. So according to the WHO guidelines, the iron deficiency or through using the serum ferritin in the word of microgram per liter is that if the infant between 0 to 23 months, the approximately healthy individual has a less than 12, and the individual with the infection and inflammation is a less than 30 iron deficiency. For the apparently healthy individual, there is no risk of iron overload is there. But for the preschool children, they have also the same, but the age between the children between 5 to 12 years, they are between less than 50 and less than 70. And they have a different pregnant woman less than 50 in the first trimesters. And if we talk about the older person, 60 years age, they have a value of apparently healthy individual with the risk of iron overload is greater than 150 in female and 2,200 in the males, as compared to the non-healthy individual of greater than 5,000. So this is the recommended cutoff value to define the iron deficiency and the risk of iron overload in apparently healthy and non-healthy individual at a different age group. So iron deficiency and over can be on the basis of physiology, can be overlooked. In the second part, we have to discuss about the clinical application. You can see that the ferritin levels are increased in the following cases. So what are the causes which may increase the ferritin levels, or which are the causative agent for the increased level of ferritin due to the iron accumulation? The genetic hemochromatosis, the hereditary or a genetic aceruloplasminoanemia, the secondary iron overload from the blood, transfusion or excessive iron, intake and administration. So the thalassemia minor patient has elevated ferritin levels because they have a repeated blood transfusion. So they are overloaded with the iron. That's why the condition of secondary iron overload from the blood is occurs transfusion, and then this happened. Ineffective erythropoiesis, sideroblast anemia, some myelodysplastic syndromes like refractory anemia with the ring sideroblast, thalassemias, atransferrinemias, ferroportion and disease like increase in serum ferritin synthesis not associated with the iron accumulation is the malignancies, malignant or the reactive histocytosis, hereditary hyperferritinemia with and without cataract, Gaucher's disease, acute and chronic infection disorder, autoimmune disease. So the liver disease include the liver necrosis, chronic viral hepatitis, alcoholic and the non-alcoholic steatosis, chronic excess alcohol consumption. Ferritin levels are decreased in the following in iron deficiency hemodialysis situation. So these are the clinical utilization of ferritin level increase and decrease in different conditions, especially the anemia or some hemodialysis or some iron deficiency cases. Any question, if you have, you can ask, please. So if we talk about the ferritin have different conditions like anemia, hemochromatosis, tumor, or in 2019 SARS-CoV-2 inflammation. So everybody wants to need about the ferritin, and the ferritin testing is more clinically significant. So if we talk about the anemia, we have discussed in details about the anemia. As you know that the anemia is a condition in which lack of healthy red blood cells to carry adequate oxygen to your body tissues. It is most common blood disorder, and it's a condition in which develops when your blood produce a lower than a normal amount of healthy RBCs, and the main reasons for the anemia is the iron deficiency, because the bone marrow need the iron to make the hemoglobin, because the heme is the iron, and the globulin is the protein present in the bloodstream, and then they combine to form a hemoglobin, which is a carrier of oxygen from lungs to the different organ and tissues of the body to maintain the integrity and the survival of these living tissues. So if we talk about the normal RBCs, you can see that the normal RBCs shapes and size are some spherical shapes and dumbbell like 6 shapes. But in some anemic conditions like iron deficiency anemia, the RBC's shape has some typical numbers of RBCs in the bloodstream. They have the low hemoglobin. The shape of the RBCs is changed, and even in the sickle cell anemia disease, the RBCs are not capable to carry the oxygen from from the lungs to the other organs and from to perform that. So this anemic conditions has a vital role played by the demographical factors, the dietary factors, and the socio-physical factors. In the demographical factors, the widowers, immigrant, aborigines, those people who have been originated births in a plant, who has been countries or region from their earliest time, that's called aborigines. And then the female, where the teenagers, the elders patient play a very demographic factors to have an anemic condition. If we talk about the dietary factors, the low iron, the hemoglobin iron, and the low vitamins concentration is there. The excessive tea, coffee, the fat diet is there. and then if you have the poverty, and then this is that right risk. So the very high risk about that, alcohol abuse and socio-physical factors that involve in that deficiency. So if we talk about the sign and symptoms, the typical sign for the anemia, as you know that these are the headache, insomnia, the shortness of the breath, the fatigue, dizziness, difficult concentration, the pale yellow skin, and in the anemic condition, the RBCs, numbers of RBCs are less as compared to the normal blood samples, and this may lead to the deficiency and the capability of the blood to carry the oxygen from lungs to the different organ tissues. We have discussed in detail about the pathogenesis. In the pathogenesis, there are two types. If the RBC's production is decreased, or maybe the RBC's production is increased, or the blood loss is occurs. So this is the pathogenesis condition in which the condition of anemia is occurs. So if we talk about the decreased RBC production, what are the causes of decreased RBC production due to either the iron deficiency? There's the prolonged negative iron imbalances occurs. So the RBC production is normal, but the iron is not in the body to bind with the globulin to carry the oxygen from different organs to the lungs, and the lungs to the different organs. So the nutritional deficiencies like vitamin B12, folic acid, vitamin A and C deficiency may also lead to the decreased RBC's production. Neoplasm of the bone marrows has a deficiency to produce the RBCs. And if we increase the RBC breakdown, which shows infections in case of malaria and the genetic disorder like thalassemia, sickle cell anemia, or a chronic inflammatory disease, due to which the RBC production is breakdown, and that may lead to the low number of RBCs in the bloodstream. The blood loss due to some trauma, GIT bleeding, and that extra reason may lead to the anemic condition. And this anemia is the outcome of the imbalance between the RBC production and the breakdown. So that's why we call them anemia condition. So if we talk about the primary diagnosis for the anemia, anemia is measured according to the amount of hemoglobin. That's the protein within the RB cells that carries oxygen from lungs to the body tissues. And anemia is decrease in the total amount of RBCs or hemoglobin in the blood. So according to the WHO guideline for the diagnosis of anemia at the sea levels in terms of grams per liter, they have classified to a non-anemia the population of children at different ages, with the non-pregnant women, with the pregnant women, and the men. For the non-anemia, the value is 110 or higher. For the children between 6 to 59 months of age and the 5 to 11 age, the value is 115 grams per liter or higher. For the children between 12 to 8 is a 120 or 120 for the non-pregnant women. For the pregnant woman, 110, and for the men is 130 grams per liter. If we compare the results of these hemoglobin in terms of grams per deciliter, the value is 11 and higher. 11.5 is higher, 12.0, 12.0, 11.0, and 13.0 and higher. So they also classify the anemia on the basis of the mild, moderate, and severe condition. According to the guidelines, if we talk about the severe anemic conditions, you can see that if the lower than 7 grams per deciliter hemoglobin or 8 grams per deciliter hemoglobin is considered as a severe anemia in different population of age of children, or non-pregnant and pregnant women along with the men. So anemia basically have an impact of 33% of the world population, and it can halve the case are due to this iron deficiency anemia. So also such chronic diseases in a woman and the children's and the man's also like the cancers are the high risk of developing anemia in some countries where they have a high risk of cancer is there or a kidney, some kidney chronic disease or a liver chronic disease may also lead to the high risk of anemia in such patient. So, if we talk about the iron deficiency anemia, according to the guidelines, if we compare the values of different serum iron levels and the ferritin levels in iron deficiency anemia, there's a typical picture of having a serum iron level is low, the ferritin level is low, and the transferrin saturation of transferrin level is also low, along with the TIBC value is high, transferrin value is high, and the hemoglobin is low. This is the typical example of iron deficiency anemia as compared to the chronic disease and polypyrria cutaneous tarda and sideroblastic anemia and thalassemia cases as well. So with the vitamin B deficiency, this is also a typical example. So with the difference chart for the hereditary hematochromatosis, Brian K. Crown data for the American Academy of the Family Physician publication. This is the typical example of iron deficiency anemia given by that guidelines on the basis of the patient data. So if we talk about the hereditary hematochromatosis, so in this autosomal recessive disorders, that may lead to the body regulation of the iron, and it's this most common genetic disease in the whites as compared to the homozygotes of the C28-2 mutation in HFE gene. So due to this gene mutation, this is occurs. So this mutation can cause inappropriately increase in the intestinal iron absorption of the rate of 2 to 3 times greater than the normal. And this highest risk C282G homozygous genes prevalence is 1 in 188 in Australian population, and they increase the risk of iron overload. They have iron studies every 1 to 5 years, and the family members need testing. So the advice, if the serum ferritin is elevated, they need to begin venesections, candidates for the therapeutic venesections, and family members need testing. Along with that, the SF value, serum ferritin values is greater than 1,000 micrograms per liter. Refer to the gastroenterologist, hematologist, and physician with an interest in iron overload. So this onset is usually earliest for the mans compared to the woman, because the woman's common symptoms include abdominal pain, weakness, lethargy, and unintended weight loss may lead to that. For the low risk HFE genotype, H630D homozygous, check in the iron deficiency in every 1 to 5 years. And these are carriers of different autoimmune recessive disease, hereditary disease, is 1 in 8 and 1 in 5 and 3 to 5. No further follow-up is needed, only that the asymptomatic treatment is required for such patient. So if you go to the hereditary hematochromatosis, for the serum ferritin level, if it's elevated, then the elevated serum ferritin level due to some hereditary hematochromatosis, or some serum ferritin level is also elevated. There may be some hyperferritinemia due to the metabolic syndrome, fatty liver, insulin resistance, diabetes, or the obesity. So the total body iron levels raised and the normal, and these are the few features on the basis of which the serum ferritin levels and the overtime prognosis more elevated helps them to support the comparison between the elevated serum ferritin and hematochromatosis and in the metabolic syndrome. So this is a typical example for those who are having such condition in this, so they can treat through this monitoring levels. So the hereditary hematostatus in the diagnosis, according to this algorithm for the management of patient with homozygous hereditary hemochromatosis, is that in the management of the homozygous hereditary homocysteine shows you that this heredity is in an adult 18 and the older age is fine. So this is very detailed. If we want to show you that more, that the patient is symptomatic, if the patient is asymptomatic or the first degree relative with the hereditary hematomatosis, they can go for the measuring a serum ferritin levels and the transparent solution. So once they have did this, you can see that they have to go to a transferrin saturation level is less than 45. The serum level, ferritin level, no further testing is needed. But if the serum transferrin saturation level is more than 45% and also have validated some value of 300 nanogram per ml, so they have to go for further proceed for HFE gene testing. So the heterozygous for the C282Y or homozygous for 282 heterozygous guy referred to a gastroenterologist and a hematologist for further workup and positive liver biopsy to rule out the liver cirrhosis and then some other gastroenterologist process. So if we talk about the hereditary hematochromatosis, the serum ferritin level elevated over the time, progressive more elevated, fluctuated in the metabolic hyperferritinemia due to the metabolic syndrome. If we talk about the ferritin in malignant process, which is called hyperferritinemia, is basically a common in a cancer patient, the breast cancers, the lung cancers, liver cancers, ovarian, stomach, and neuroblastoma in the children as well. In non-Hodgkin's lymphoma and the Hopkins disease, such where the serum ferritin behave as a poor prognosis factors when elevated. It's according to the annals of the hepatology, the serum ferritin levels between 300 to 1000 microgram per ml, and the malignancy may also unknown as are the mechanism for the hyper ferritinemia in the various disorders is also occurs. So there's another ferritin phagocytic lymphocytosis in this journal. According to the case, this diagnostic criteria was established in 1991, and in the Histocytic Society proposed a standard set of 5 diagnostic criteria for HLH. So for this diagnostic criteria perspective, these criteria were revised by 2004. Individuals need to be meet 5 of 8 diagnostic criteria. So this hyperferritinemia should always be prompt includes of the HLH in the differential diagnosis, that the further value characterization of HL in the adults between 7,000 to 10,000 milligram per liter and really maybe have 100,000 milligram per liter. The ferritin level is 10,000 mg per year, 90% sensitive and specific for LH in children, and they need to meet the criteria. So the ferritin level is greater than 500 microgram per ml, and the other testing which helps the molecular diagnostic consistent for the HEL will help the great support to diagnose this HL 2004 diagnostic criteria meetness. So if we talk about the ferritin in the liver cirrhosis or other malignancy, it's also increased serum ferritin levels in the malignancy, especially the liver metastasis, and well as the liver failures or the toxicity, which turns on the responsible for the cytolysis and the other intracellular ferritin into the bloodstream. So if we talk about the ferritin level in COVID-19, ferritin was a key mediator for the immunodysregulation, especially under the extreme hyperferritinemia via the direct immunosuppressive and the pro-inflammatory effect. So contributing to the cytokine storms, many individuals with the diabetes exhibit elevated serum ferritin levels, and it is now that the face or higher probability to express serious complications from COVID-19. If you talk about the more clinical utilization of ferritin in the COVID-19, you can see that how the SARS-CoV-2 infection have an pulmonary epithelial, and then they induce the macrophages, and then IL-6 and 10 along with the ferritin secretion has an lymphocytes, and then immune suppression with the macrophage activation and immune activation for the ferritin immunodilatory effect as a come. So the complex feedback mechanism between the ferritin and the cytokines is the control of pro-inflammatory and anti-inflammatory mediator, which exists as the cytokines can induce ferritin expression, but the ferritin can also induce the expression of pro and anti-inflammatory cytokines. So again, the ferritin in COVID-19, there's a very comprehensive ferritin levels along with the timeline, sample size, and COVID-19 diagnosis with the secretary's classification along with that. So if we talk about the ferritin in the COVID-19, it suggested the use of ferritin values as a marker for the COVID-19 infection. The data story confirmed that the increased level of ferritin were directly relocated with the decreased severity. So what we have a solution from this knife platform. So we have a very comprehensive solution along with the conventional solution. We have a ferritin assay with us. So the SNI ferritin. Along with the other competitors, we have also a ferritin with the additional EPO assay for the anemia rule out. The other competitors, they do not have. If we talk about the ferritin, first generation and second generation, within the generation, we have an improvement in terms of measuring range. The sandwich principle is same. The measuring range is improved in the second generation, and the overall serum and plasma type is also improved, and the standardization material is same like WHO 94 by 572, and we have a concept of limit of blanket detection is improved process. The onboard stability is 4 weeks, and we have a 50 and 100 test pack size available from the Meglumi platform for the ferritin assay. So if we talk about in comparison with the other competitors, so we have a very comprehensive comparison with the SNI, with the Abbott, the Beckman, and the Roche and the Siemens. If we talk about the ferritin, we have a sandwich principle as compared to the Beckman, Roche, and the Siemens. The Beckman and Abbott is also a sandwich principle. We have a broad measuring range as compared to the other competitors. We have an optimum sample volume. We have a 31 minutes assay time. We have a serum and plasma. Both are recommended on the second generation ferritin, but in the first generation, we have a serum sample type is only recommended. The traceability is according to the latest guideline of WHO, that's a standard material of 94 572. We have an equally good results as compared to the Beckman and the other competitors with them. We have a limit of blanket detection. We have a 4 weeks onboard calibration frequency recommendation. We have edge of 50 test pack size. Oh, sorry. So if we compare about the backman versus the snipe in terms of stability, you can see that the onboard reagent stability is 4 weeks and they have a 28 days. The second edge, what we have in terms of stability, we have a pack size of 100, which is matchable with the backman. If we compare that the patient or a customer have a low number of sample for the ferritin, they can use our 50 test pack size, which help them according to their low volumes of lab testing. They help them to report that patient without having a more frequency of calibration and control. So we have an edge in the pack size for those niche parameters who required their volume, desired volume, but due to the pack size, the customers cannot use that. But in our system, we have a flexibility. The second, maybe the backman has a pack size of 100 multiplied by 2 is equal to 200 test pack size. So they have to buy a more reagent for those analytes whose workload is comparatively low as compared to the other parameters. So the investment of the end users is increased in such cases due to the limitation of the pack size and the number of tests per test per kit, right? The second thing is about in comparison, not only the stability, the calibration stability, and onboard stability. The other is a broad measuring range. We can read the ferritin level up to 3,000 nanogram per ml. If we compare with the competitors like Beckman and the others, they need a dilution to report a one patient. Like the thalassemia patient, they are usually a higher value of the ferritin. So they need maybe 2 or 3 tests to perform a ferritin on backmen, while within 1 or 2 tests, we can give the results because our linearity is up to 3,000. But in the thalassemia patient, they have may have 8,000, 12,000, 16,000, 22,000 value of ferritin. So within a 2 test, it is concluded that our assay give an economical solution for the thalassemia based patient anemic condition rule out. So if we compare with the data, have a comparison with the commercially available ferritin in the market. Our first generation immunoassay, they have an on the basis of 100 numbers of samples. We have a regression value of 0.99, which shows the excellent correlation of our Maglumi SNI ferritin versus the other commercially available ferritin, and they have covering the broad range of patient with the regression patient value of 0.001. So if you further go for a second generation, we have an edge of broad measuring range and the number of tests, which was equally good in the ferritin second generation. And the edge of serum and plasma, both types are available in second generation as compared to the first generation was only recommended for the serum value. If we talk about the regression value for the second generation ferritin value, that's with the commercially available ferritin, we have a 0.99 regression value on the basis of 49 samples. So using these clinical samples give the excellent correlation of SNIPE second generation ferritin as compared to the other assays of other competitors' assays. So this is all about the anemia, EPO, and the ferritin assays. So if you have any question, you can ask. Otherwise, we have to take one picture or we can close that case. Okay. Any question you can ask? Okay. So I need one picture before ending this session. So I will take you just 1 minute, right? Okay. So if no question, just give me a 1 second. So I have to give you the one. How long does the reagent last after its expiration date in your experience? Okay. So very interesting question. I really appreciate that question. Uh, Usually the average onboard stability according to the package insert is 4 weeks, right? But my experience that if the workload is low, the Meglumi Snipe essays has an capability. You can take it out from the onboard, make a put a tape on the top of the reagent and put it into the refrigerator. If there is no patient is coming or a new the samples are less, so you have to perform it and then you can place it into the refrigerator. But if unused reagent, keep it on board. The reagent stability is practically 2 months and 3 months. But in the package insert, it is recommended the within the 1 month you have to finish the reagent. Otherwise, you may need a repeat calibration and QC frequency may increase, or the reagent performance may compromise. So the IFU recommendation is 1 month, but the practically keeping reagent on board 1 month, maybe 2 or 3 months is practically proven. But if you want to enhance more, you have to keep the reagent only on when the patient samples are available. So it is better to keep the batch mode for those analyte which you want to keep run for the longer period without compromising the wastage of the reagent. So this is the best practice. If you have a low volumes of EPO or ferritin, you order the smaller pack size, or if you don't want to order the smaller pack size, you can use the 100 test kit within the 1 month. If it's 100 test kits are not okay, you can consume within 2 months by keeping the reagent sealed in a refrigerator. On the basis of need, you can load it and then run it. So this is the right answer for your inquiry. Okay, so Artem, this is your confirmation that the Backman has a pack size of 15 to 2. So this 100 is a cartridge of 52 cartridges. Okay, so but if we compare the Backman 50 pack size, like if we talk about, let me share with you that slide. Can you see my screen? Okay, let me share with you uh, this slide, right? For the ferritin, right? So, so here, this is 100 test means 50 into 2. This is the pack size for the Backman, right? So if the Backman pack size is 15 to 2, it means if the 50 test kit is 100 ruble, so the two kits price is 200 ruble, right? So in our case, if 100 test pack size is 100 ruble, so the 50 pack size is 50 ruble. So the investment is low in the snipe case as compared to the backman. They are forcefully providing or pushing reagent to the customer to must buy the 100 test. So the customer cannot buy less than 100 test pack size of backman. But in Snipe, we have innovation that we can provide 50 test reagent pack and the 100 test. It depends upon the customer utilization. Okay, is it clear? Yes, Artin, Urin, you are right. In terms of two kits, like 50-50 test, two kits, the stability, one kit is, for example, 28 days, the other is 28 days. So altogether 56 days for the 100 test. But in our case, we have option of 100 tests. If the customer is not able to consume the 100 tests in 30 days, they have an optional 50 test pack size. They can be used for 30 days. So if they want to enhance the onboard stability, if they have any problem with the 50 test, they can put the reagent on board when they want to run the patient. So with this procedure, they will enhance the onboard stability or the calibration interval of all the reagent which are slow running parameters or have called trouble analytes, those analytes which onboard stability is compromised. Yes, in the past, Artem urine, that was in the past, they have some cases, they have written that they have 100 test pack size, and Beckman usually they are offering 100 test plus 50 into 2 test pack size. They both, I know that they are providing 2 pack size. But in this case, if they have a 50 into 2 pack size, that means the customer need to purchase a pack sizes kit pack size is 100 test, but individually they have a two cartridges. So they have write the pack size, not the individual vial testing system in Beckman and even in the Siemens. You can see that in the Siemens, they have written that this is a 50 test pack size. So there are two terminology we can use. I can write here. There are two terminology and kick size, right? Okay, so I will make a one note for you to have a comparison of anemia, EPO, and these essays for Mindray. So they have this, but I'm not sure why they didn't add the Mindray comparison of anemia and EPO and ferritin in this presentation. But when the last time when I asked with the tumor marker, they have a comparison with the Mindray. So if you Artem Urine, if you want that, I will forward your inquiry for Mindray comparison. If you are interested with the Mindray comparison, the Chinese colleague in Russia, they will share with you. Okay. I agree. I agree. You have a big competition with the Mindray, and they have some product. They have a good feature, but they are not good in precision. If you run the precision according to the CLSI guidelines, the instrument performance is not up to the mark. Yes, it's very important. So, Artem Yurin, I will forward your inquiry related to the comparison for today's presentation for tomorrow. Let me give you the one questionnaire and training feedback link. Just give me a 1 second. So then we will close that presentation, right? Okay, just give me a one. So tomorrow you have a session on D dimer, cardiac marker, BNP, and anti-pro BNP, right? So after this tomorrow session, you need yes, Artem, for the future is very much important. I agree. So please, all of you, save this link in your computer, in your mobile, because after tomorrow, same day session, same session for D dimer, same timing session for the D dimer, cardiac markers, pro BNP, and anti BNP. So this questionnaire for the application training is required, right? So thank you very much. If you have any further inquiry, I will convey your message for the mid-ray comparison to my core team, and they will respond you. Right, Artem Yudin? Thank you very much. Or if you have any inquiry, you can drop me a message. Otherwise, tomorrow we will meet again the same time. Thank you very much. See you. Take care. Bye bye.